I won.
Okay. Thank you. So good evening, Prof. One. Thank you for joining us.
Hi. Hi, everybody.
So Arif,
I hope you have prepared something to eat for us.
What? Are you sitting in Paris one or?
No, I'm sitting at home.
You never know.
Yeah, I would expect some beer or something.
It's aperitivo time, I would say in Italy, yes.
Ciao tutti. Hello, how are you?
Hi there.
Good, good. Hello, Costanza, nice to meet you. Prof. Kim, pleasure to meet you. And again, how are you?
As far as now, very fine, thanks.
Good, 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 good. Excellent. Welcome to everybody joining us and connecting, just setting up the YouTube live link. So we're good to go. So we'll get started in about a couple of minutes. We'll just let everybody either finish from work, finish from cath lab, finish from whatever they're doing, and then we'll get started in a couple of minutes. I've activated screen share. So if you want to try and see if it works on your end, just so we know we're good to start.
Oh no, they changed something, blah, blah, blah. Okay, so does it work somehow? I'm trying again.
Just try.
I never had problem with this. Is there a special firewall or something else?
Nope, it's set up, so it should be working fine. Let's have a look. Is it working at your end?
No, so far not.
Okay, why don't you try leaving and then rejoining again?
Yeah.
And that might do the trick.
I'll try, yeah.
And in the meantime, if I can ask, perhaps, oh, here we go. There we go.
No, I shared mine.
Perfect, perfect.
Okay.
You read my mind. I was going to say if somebody else can share just to know we're working. So that's good. So Costanza, I'll just ask you maybe if you leave and then
yeah, I'm leaving.
Meanwhile, I can show you the results of our poll. Arif, if you want to comment.
Yeah, so we asked the poll because there's a lot of discussion nowadays about type of valve choice, and particularly as the field of TAVI is now moving more and more towards low-risk individuals, younger patients, choice of valve or valve one is becoming a real hot topic. So we asked the question, when you're choosing a particular valve type, what is the most important thing that you're thinking of? So gradients, PVL, coronary access, or let's say a more sort of medical, depending on the patient age. And over 55% of you voted that it depends on the patient / the age. Then it seems that people are focusing on gradients and also paravalvular leak with coronary access featuring less important. So I think that's a very nice basis and a good way to start the discussion for the trial and the study today, which compares to new generation. We've got the balloon expandable and the self-expanding platforms. So yeah, so let's see if Costanza's back on and if the screen share is working, and then we can get started. So we'll just connect in a couple of minutes. In fact, as we're waiting for Costanza to come back on, Professor Kim, can I ask you a question? So you've seen the poll results. In your practice, which of those four things, so depending on the patient age, gradient, PVL, coronary access, what are you thinking when you're choosing the valve choice?
I'm thinking of everything.
Yeah.
And if you can achieve low PVL, low gradients, and good coronary access, of course, this would be desirable, but yeah, sometimes you have to make compromises. And I think before we think of these factors, the utmost important thing is to achieve procedural success. And even nowadays, when we have made a lot of progress, but we still see cases which can have really severe complications and sometimes even fatal outcomes, even after this learning curve and experience. And I think the highest goal must be to have a safe delivery of the valve, a good position, and you have to be on the safe side. And then if you can choose between 2 or 3 valves that you think of will achieve procedural success, and then you can start to choose which valve will have less PVL, which will have the best hemodynamic profile. And I think there are signals that indicate that hemodynamics do play a role, prosthesis mismatch. We have to think about this factor in terms of long-term outcomes. And coronary access, of course, if you can preserve coronary access, it's a very important thing. I think also pacemaker does play a role.
Right. Thank you. So I think that's a perfect introduction into the discussion. So Costanza, I can see everything is working. So good evening, everybody. Welcome back to Journal Club. It's a tremendous pleasure to have you all joining us. And we're very much looking forward to Costanza presenting this very important hot topic, which is published in your intervention. And a very warm welcome to the first time for Professor Vaughan Kim, will be joining us as our expert today. So thank you for joining us. We hope you enjoyed the discussion. And if you have any questions, please type them in the chat, or you can ask them live at the end. So over to you.
Thank you very much for first of all, for the invitation and for the introduction. I hope everyone can hear me now. We had some technical difficulties, but now we get right into it. So I would like to present you the work we did with one. It's a comparison of the latest generation Acurate Neo 2 and the Sapien 3 Ultra valve. And why did we do this study? As we all know, there was the Scope 1 trial, a randomized controlled trial, which tested the first generation Acurate Neo as the self-expanding against the Sapien 3 as the balloon expandable valve in a randomized fashion, and a little bit against the thoughts. The Acurate Neo failed to achieve the non-inferiority margin. So this was a little bit a drawback for this valve. And I have to say, we performed a study also still with one, comparing these 2 valves, and we used our real world data, and we didn't saw these huge differences which were seen in the Scope 1 trial. So besides the clinical endpoints that made up the composite, the primary endpoint, a very important thing that was seen in the Scope 1 trial was that the Acurate Neo, the self-expandable valve, had a lot more of moderate or severe paravalvular regurgitation. And I think this is the Achilles heel of the Acurate Neo valve. So we were curious, now that there are new platforms available for both valve types, if these differences are still noticeable, or if the technical iterations or the technical improvements led to better results for both valves, or how the 2 valves compare with each other. So I don't want to go into details. I think many of us use both valves in the cath lab. Just maybe the biggest difference for both valves is the augmented sealing skirt, which is augmented for over 60% for the Acurate Neo and also for the Sapien 3 Ultra. And there were studies, also just registries, showing that both valves showed a better performance compared to the its predecessors. However, comparison of these two was still not available in the literature, so we thought, why not do it and find out ourselves. So what we did is we included patients, over 1,300 patients over 2 years from 4 centers in Germany, Munich, Bad Nauheim, Essen, and Gießen. You see the small dots where they are located in Germany. And we enrolled more than 600 patients for each arm. And to account for baseline differences, we performed nearest neighbor matching, correcting for variables which we saw were a little bit different between the two populations. And in the end, we had 2 study population of 472 patients each, comparing these 2 valves. And for endpoints, we decided that the primary endpoint would be device success, VARC3 coded, so with some differences compared to the previous definition of device success, mainly going to 30 days, and also the if surgery was needed until 30 days. And the secondary endpoints, we focused on technical success, also composite VARC3 endpoint, as well as clinical endpoints up to 30 days. If we look at the baseline characteristics of our study population, you will see that there were some differences, a little bit age difference, gender distribution was more female in the ultra cohort, but the one most important difference is the difference in logistic Euro score, which is a little bit higher in the NEO2 group, and a higher rate of patients with coronary artery disease in the ultra group. This, I don't know, I missed a little bit the introduction that one gave, but I just heard that coronary access was mentioned, so maybe we can talk about this later. Another important difference was the type of or the anatomic features of the valve. We had lots more bicuspid valve in the ultra group, as well as more asymmetric and more heavily calcified valves in the ultra group. So for these reasons, we performed the matching to try. Of course, it's not a randomized trial; it's just a registry, but to account for these differences, we performed, as I mentioned, the propensity matching. And what I would like to point out in this slide is just that there were no differences or no significant differences anymore after matching. So we have really 2 well-balanced populations that we could analyze. If we go and have a look at the procedural outcome, most of the procedures in both groups were performed under conscious sedation, which I think represents the routine nowadays. There was no difference in procedural time, which is important, as if we go to see the dilatation strategy for these 2 platforms, there is a big difference. There is much more, or has been much more pre-dilatation in the NEO2 group, as well as much more post-dilatation in the NEO2 group. And nevertheless, even if there was this difference, so leading, or one could think there would be longer procedures for the NEO group, this was not the fact. This was even shorter in the NEO2 group. For the endpoint technical success, which was one of our main endpoints, there was no difference. Both valves performed, I would say, perfectly, or perfectly not, but really good, with outstanding results, more than 95%. And these findings, as well as the differences in dilatation strategy and the comparable rates of technical success, were also seen again in the matched population. It's a little bit different, however, if we move to the primary endpoint, device success. There we found higher rates of device success in the Acurate NEO2 group. So 8.1% of device failure against 15% with the ultra valve. And to be sure that this finding was not just a find of chance, or to be a little bit have a stronger statistical background, we analyzed this just in univariate, as you can see in the diagram, in a multivariate analysis accounting for all important endpoints, and also with an inverse probability of treatment weighting, and in the propensity score matching. So in every statistical approach, we found the same solid result, that device success is higher with the Acurate Neo compared to the Ultra Valve. Why was, or what was the main driver for this finding? It was the presence or absence of elevated gradients. Elevated gradients are defined as gradients above 20 millimeter mercury. And as we know, the Acurate Neo before already in the Scope 1 trial showed that the gradients were lower. And even if now there is this larger sealing skirt, the valve, the new iteration of the valve maintained the lower gradients. And you can see here the absolute numbers, and on this side of the screen you see how for both platforms the gradients, of course, they fell after TAVI. Otherwise, why do the TAVI? But there was a significant difference with a single-digit number for the Acurate Neo and a 13 millimeter Hg for the Ultra Valve. Besides this finding of gradients, another important hemodynamic parameter to evaluate the valve is of course the paravalvular leaks. And is, as you can see here in the diagram, there was almost, or very, very little moderate paravalvular regurg, and there were no severe at all. So that, I think, is a big difference. If you remember the diagram I showed from the Scope 1 trial, where there was this big fat part for the Acurate Neo of moderate and severe regurgitation, there was a big incrementation in the sealing capacity of the valve. And there was no difference between this 0.6 and 1.1 of the Ultra. Against this background, also I need to point out there was some more mild PVL compared to the Ultra, and the Ultra was really had a significant higher rate of no paravalvular regurgitation at all compared to the Neo 2. And another important aspect, I think, that one mentioned before, was the presence of patient prosthesis mismatch, which I believe is an important measure of the hemodynamic valve performance, and will play a more important role as in the time, and with the fact that we will go to treat younger patients, and we will see the effect of a patient prosthesis mismatch in with longer follow-ups, which we will get only in the next period and in the next years. So this was, sorry, I didn't say it, but it was significant lower, the presence of severe PPM with the Neo 2 group, and also the AOA was larger with the Neo 2 compared to the Ultra. We followed the patients up to 30 days. Follow-up was pretty much complete, I think, above 95%. So there were no significant differences here from mortality or stroke and rehosp. And here I would like to point out the levels, or the rates of pacemaker. They were similar for both valves, so, and similarly low. They were I see I forgot the percentages, but they were both in a single digit percentage. And I think this is important because the fact that both valves got a larger sealing skirt, it didn't affect the happening of conduction abnormalities, and so still both valves had good results with the pacemaker, with the Acurate Neo 2 having still lower pacemaker rates, even if not statistically significant. And with this, I think I will conclude that both valves showed really good technical success, were comparable also from the event rates at 30 days, so for a short clinical outcome. However, the Acurate Neo2 showed higher rates of high success, mainly due to lower transprostatic gradients. And the rates of PVL, so the second very important measure, or maybe the most important measure of hemodynamic performance, were really low and comparable with both valves, but PVL or mild PVL was seen even less with the Sapien 3 Ultra valve. So, and with this, I thank you for the attention, for the invitation again on behalf of the whole team who performed the study.
Great, thank you, Costanza. Very nice presentation. Congratulations again for this piece of work and what you've done. It's a great summary as well in the presentation. So, Professor Kim, if I could invite you, please, to share a commentary on this study and let's say the field in general when it comes to valve choices, and then we'll open the floor for questions to the audience.
Thank you very much for the invitation. I think it's a very great platform, and also was a pleasure to collaborate with Costanza, Tobias, and all the other centers. And of course, without their contribution, this would not have been possible. So great thanks to everybody who contributed. And I think the most important message is that nowadays we have to have a differential selection of the best possible valve for each patient. And this depends on the individual age and anatomy, and especially which result you will expect. And we have to be a little bit careful because this is not randomized. And this is from 4 centers, of course. I think we have a sufficient number of patients, so the population is quite fair. What we have to take into account is, of course, that with the Acurate Neo, we did not treat those with extremely calcified anatomies. This we have to acknowledge. And even after propensity matching, probably we are getting more courageous to treat severely calcified anatomies. And this is possible. We have shown that this is possible. Really depends on the distribution of the calcification, not the total amount. And you can tackle more calcified anatomies, but we did not treat those with extremely calcified anatomies. And probably if you would compare this subgroup alone, then you would see a difference in favor of Sapien on the one hand. On the other hand, you might see a higher number of annular ruptures or other complications, high residual gradients. So those with extremely calcified anatomies are not a good population, and probably they are only a few percentage, maybe 2-3%, and all other patients can be treated as long as the annular sizing range allows it. And so the message that I took, or my principle is, I think there are some advantages that the Acurate has, which is lower gradients. The pacemaker rate is quite low. We have a relatively good coronary access. So if I consider a patient, if I think with this implantation, there will be no PVL and the sizing range is okay, then I prefer to choose an Acurate. Especially when the annulus is small, because we know the smaller the annulus, the higher the risk of prosthesis mismatch. And I think we have seen the scope data at 3 years that the curves are crossing in favor of the Acurate. So this could be a signal that despite the higher rates of PVL that we saw in the Acurate group, this might be there might be a trade-off due to the gradients. So, but we don't know. We have to wait for longer-term data. And I think the role of prosthesis mismatch and higher gradients has to become more clear. We need to have more evidence, but there are some signals that we have to take seriously. There was a question from...
Yeah, maybe we can go through some of the questions. So there's a couple of questions actually from Amar Mansour. The first was about the high rate of post-dilatation with the NEO, despite a higher rate of pre-dilatation, and then subsequently the impact on cerebrovascular events. And then the second question was about cutoff value for calcification by CT as to when you would not want to use a NEO2.
Yeah, good questions. So the cutoff, I don't recall a cutoff. I think the highest patient that we treat had a calcium score of 9,000, which is really high. And this patient had a very good outcome. So it's not the absolute amount that plays a role, but the distribution. You can have a calcium score of 2,000, but if the calcium is at the wrong place, then you will have PVL. So the distribution plays a role. And I can explain to you the relatively high post-dilatation rate. And for the Acurate, and there is a trend, at least in our center, that we try to post-dilate those with residual gradient, or if I think that the stent is not well expanded. And there is evidence if we do post-dilate generously, then we can reduce the rate of prosthesis mismatch. So I'm very generous to post-dilate, even though there is no PVL. So I think around 20%, 1/4 of patients that we did post-dilatation was not for PVL, but in order to improve the gradient. And cerebral ischemic lesions, we have no data on that with MRI, but the stroke rate was more or less comparable. So I don't think that there is a big impact on that.
Okay, next questions.
Hi, I'm Marcella from Rimini. Hi, I just have a question. I noticed that the rate of pre-dilatation was higher in Acurate Neo than Sapien. Do you think that this could have a role in the differences in the gradient for the two valves? Also, was not common that most of the female had Sapien in this registry, and then you had to match the population. There was a particular reason for that, or was just registry casual? Thank you.
Maybe, do you want to comment on this?
Yeah, thanks for the question. Very good question, of course. I would start with the female part. I think, to be honest, that it's more a play of chance or a chance finding, because if women have smaller anatomies, we try to treat them more with the Acurate Neo platform to achieve even lower gradients and for the fear of patient prosthesis mismatch. And I don't know one at your center, but I think it's the same. I wouldn't see another reason for treat women with the ultra valve. And the other question was the high pre-dilatation rate.
Pre-dilatation, that it can have a role in the differences in the gradient from the two groups, or just about the valve.
I think, to be honest, that it's more the valve design that leads to the lower gradients, but the pre-dilatation is needed to allow for the valve to expand, to fully expand with its own radial force. I think there was analysis from the Italian registry where you looked at at patients treated with and without dilatation in Neo, and there were very similar results achieved from the clinical point of view and from the final gradients, if I am correct, if I'm not wrong. So I think that it's mainly a difference between the design of the valve.
Yeah, I agree. The pre-dilatation is necessary to prepare, especially for the Acurate, because the opening force is lower and you have to do a good preparation. It's like you do PCI and do balloon predilatation. And for the Sapien, I wouldn't think that this plays a role, because you have such a high radial force due to the balloon by itself. I think for the Acurate, what is more important is that you have efficient post-dilatation if it becomes necessary. Yeah, so in our center, we do invasive pressure tracings. And if I see only 1 or 2 millimeters mercury peak-to-peak gradient, I'm very generous. Because if you have like 5 millimeters of mercury, most would say it's nothing. But with 5 millimeters of mercury peak-to-peak, later on you will have a 2-digit mean gradient on echo. So I'm very generous with post-dilatation because I'm thinking in terms of long-term outcome. And for the Sapien, I think one problem, of course, it's the design that plays a role. But I think another problem is that is the sizing range. And I think the sizing range that is covered with those 3 or 4 sizes is not good for those in-between sizes. And I think there could be an advantage of having more in-between sizes like the MyVal by Merrill. And I think this really plays a role, because sometimes there are in patients that we treat with Sapien, there are sizes that I'm really not happy with. It's sometimes the 23 is too small and the 26 is too large, and then you have to compromise. Either you take a 23 and put 2 cc more volume, or you take a 26 and have less volume and risk annular rupture. I think this could also play a role for the Sapien side.
Okay, great. So Evelina, I'll go to you now.
Oh, hi. I have a question for Costanza and one for Prof. Kim. For Costanza, this is probably a spoiler. Are you planning to do a sub-analysis regarding the conduction disturbances in this population? Because you experienced a very, very low rate of pacemaker after TAVI. And I think in this population with current platforms, it would be very interesting to see how they performed in case of pre-existing conduction disturbances, and also in those who developed conduction disturbances after TAVI. So I don't know if you are planning to do this. You already did this in a paper that was recently published in Neurointervention. So probably this is going to be interesting. And also for Prof. Kim, we know for sure that if we do not achieve a good procedural outcome, we will have troubles in the future. And especially if we have a severe pacing prosthesis mismatch or a severe paravalvular regurgitation. But do you think, on the other side, that achieving the best possible result in your procedure will have a significant impact on durability? Because, of course, we are implanting Acurate Neo since 2019, I think, the latest valve. So we need to collect longer-term follow-up. But do you think that actually starting with lower gradients will have an impact in longer durability of the valve? What is your opinion about this topic?
So I think I'll start to answer. We haven't planned it yet, but you never know what happens. You always get ideas from everywhere, also from sessions like this. But to be honest, I don't believe that there will be the differences we saw with the previous valve platforms. I think we will still see them with the new iteration. So I don't think that there will be such novelty in data, to be honest.
Maybe I can comment on the pacemaker rate. Pacemaker rate with the Acurate Neo 2 has been consistently low in all the registries that we've seen, also from the Italian registry that compares Neo 2 versus Neo 2, and it's 1 digit. And in this comparison that we performed, also the Sapien pacemaker rate was comparably low, which is usually between 10 and 15%. And in our registry, it was 1 digit. And one reason for this might be that in all 4 centers, probably we have a very high implantation policy, and sometimes we implant at 0. This might explain the relatively low implant. And coming back to your question regarding gradient, of course we don't know. I cannot answer you because we don't have long-term data. But I think the data that we saw with the core valve Evolute 5-year data, and also with the Notion 8-year outcomes, at least is a signal that with self-expanding and supraannular technology, there could be some advantage in terms of degeneration and long-term durability. And from my personal experience, we have implanting Acurate since 2009, I think. We started with Acurate TA, and then turned to TF, the Acurate Neo, in 2012, I think. And then 2 or 3 years ago, we started with Neo 2. And in all these years, I think we have probably implanted 2,500, 3,000 Acurate prostheses. And I've only seen 2 or 3 patients coming back for degeneration, and those were patients with AR. So the leaflets were torn, and it was not after 10 years. One came back after 2 years and another one after 5 years. I don't know. But so of course, it's only my gut feeling. And the most cases that came back for restenosis were Sapien cases. So I don't know. It's only small signals, but I think we cannot. We should really have a focus also in the future on this topic. And I think from surgery, from our cardiac surgeons, we know that the prosthesis mismatch is relevant. For TAVI, it's less clear, but there are some data indicating that this could be also important.
Okay, so I know that we are close to time, but I have to say the discussion is amazing and the insights are so invaluable. So we'll keep going. Marco, I'll come to you in a second, but I'm just going to take a couple of questions from the chat and then we'll come to you. So just to follow up, Prof, you were talking about the implant depth, and you've got a way of implanting with the Acurate. So from Boston's side, they say that we can go up to 6-7 millimeters and you don't compromise and require a pacemaker. But in your clinical experience, what is your target implant depth with the Acurate Neo, and what are you basing that on? What are you trying to achieve?
Yeah, we're trying to achieve 6 to 7 millimeters. You know, the radial pack marker is at 7 millimeters, and this is the part with the highest radial force. So it makes sense to have this to tackle this implantation depth, and the Acurate Neo is characterized by a radial outward force that is lower in the inflow part. So it doesn't matter even if you're a little bit deeper, because the radial force is getting weaker. Of course, we could go down with pacemaker rate if we would on purpose have higher implantation depth, lower implantation depth, so higher position. But I would not recommend it. And the question by Francesco is, which is the suggestion implantate. You cannot predict it, because it heavily depends on the individual anatomy. So if you have very long leaflets and high amount of calcification, you will see that if this is the leaflet and this is the upper crown, you cannot go deeper sometimes. So it is determined by the anatomy. And for me, it has become more important to have a safe anchoring without popping out. than to tackle 1 or 2 millimeter higher implantation depth. We don't need to do this. And I think you should rather focus on having a safe implantation than trying to be as high as possible. And the message is the final implantation depth really depends on the anatomy. And if you have larger sizes, you will see that usually the Acurate will end up being a little bit higher than if you have smaller sizes.
Okay, thank you. Then there's another question about the maximum balloon size, which can be used for post-dilatation with the neo valve. And similar to Evolute, is there a correlation with the valve dimensions? What's your practice?
Yeah, the recommendation is to do not exceed the valve size -1. So if you have 27, you shouldn't go above 26. And if you have 25, maximum recommended size is 24. We have done also in 27 millimeter valves in the very beginning, post-dilatation with 28, and the patient survived it and the valve survived it. But there were we had some cases where there were ruptures. The leaflet material there were tears in the leaflets. So this is the recommendation, and also it depends on the balloon type, right? If you have whether you have non-compliant or compliant balloons, but this is the rough recommendation.
Great, thank you. And then Marco, over to you for your question.
Okay. So one question to Costanza about the study. I'm interested because we have these new valves with a really good outcome in acute and during the hospitalization. So I would like to know if you have already planned a follow-up and which kind. I mean, I can imagine that you maybe use echographic endpoints, and also which may be a clinical endpoint you want to look for this for your patients in your registry.
Yeah, thanks. I think that's one for longer follow-up is definitely needed to understand how the valve will compare in a longer time, and to see, as we spoke earlier, the impact of gradients or patient prosthesis mismatch in a longer follow-up. And I think that 2 years, 3 years is, or 2 years is still not enough, but we will have to follow our patients even longer. And I think the hardest endpoint available is mortality, so that is a must. And of course, it would be very nice to follow up the patients with echo parameters. At our center, we have a TAVI ambulance or TAVI ambulance, where the patient come every year, or we try to invite them every year. But of course, the patients that you have to you have to consider that they are 80 years old in the mean when they come, and it's always hard to get them, or it's getting harder to get them back to the center to follow them up with an echo, especially over the last years here. It was very difficult because patients were also afraid for COVID-19 and they didn't want to come. But I think that would be the goal, to further assess the valve with echo to know how the valve performs and if it deteriorates and what is the main leading thing here. And the hard endpoints like mortality or stroke and pacemaker rates. Even if I don't think that a pacemaker that the patient will be implanted 2-3 years after TAVI still has to do with TAVI as well as the stroke rates.
Okay.
Comment. We will have long-term data also in the currently ongoing IDE trial. Up to 10 years, correct me if I'm wrong, but this will be embedded in a randomized data set with a lot of patients, 1,500 patients. So there will be data available, but it will take 5-10 years. And but it will be highly interesting, of course.
There is also the double choice randomized study, which should go on now again, which compares the two valves with at least a 10 years follow-up. Yeah.
So another technical question, which is continuing this theme about the implantation depth of the neo. Do you routinely measure valve leaflet length when you've got a neo valve that you're planning to implant? And there's a question about the opening mechanism, given that it opens from kind of top to bottom. Is this why the annular range that's covered is smaller with the neo?
Yeah, no, we do not measure the leaflet length, but I look at the leaflets visually, and if I have the feeling that this could be a problem, then I prefer other valve types. So it's only a gut feeling.
Okay.
Usually, if you end up a little bit higher, what you can do, what we have employed recently is because there is an increased risk of pop-out microdislodgement. If you have a higher implant position before step 2, and what you can do is besides pushing hard, but pushing too hard you can end up in the left ventricle. So you have to be really careful about that. We do fast pacing or rapid pacing, which brings a lot of more stability, and I think this has been very helpful in the since we have been working on the micro dislodgement topic, which does happen, and those who work with Acurate will have this experience. There are a lot of factors. Recently, I did a case with my chief, and step 2 was very slow. And you know, if you do step 2 very slow, you see what can happen. It has to open like this in order to anchor and to prevent popping out. If it's like this for 3 seconds, then it will pop out, and this is what happened. And there are many mechanisms that can contribute, but if you are a little bit too, so of course, step 2 has to be very fast. The new iteration will have a knob that only needs to be turned, I think, a few degrees, which makes it much more easier. Another thing is, so my recommendation, if you have a higher starting position, and sometimes you push and push, and you cannot go down to the annular plane with the radiopeg marker, and then you have to accept this position usually and deploy with rapid pacing. We do not measure the leaflet length, and I think the range of annular size, there could be some, I would say, revolution. We have compared Neo with Neo 2 data, and we found that with the Neo 2, you can have another sizing range. You can go a little bit larger than with the Neo. So I think it would, we have treated today a patient with 26.8, which is possible. We have shown it. We have a very recent publication. I think it's not available yet, but if there's not eccentric calcification, you can upsize, and even with the larger sizes. And I think with the Acurate Neo Prime XL, you will be able to also cover larger sizes.
Okay, so just before we conclude, we come to the end of the session. I would just like to ask you a question, Prof. These journal clubs are very much for young or early career intervention cardiologists and those who are connected today and will be watching the session. There's a lot of people very early on in their TAVI career, or let's say TAVI experience. So what's your, as somebody who's implanted thousands of, let's say, all the valves, if you had to give some take-home messages for us early career interventionists in terms of the learning curve with the devices, you know, you've got a fundamentally different way of implanting, let's say, the balloon expandable, and then the self-expandable, then you've got the Evolute, you've got the Acurate, Navitor as well now. So what would you say to young fellows who are starting learning about implanting TAVIs, little tips and tricks from your experience?
I think it's very important to do imaging, because from imaging you will learn to understand the anatomy, and this will also help you to perform a better selection of valves and help you to understand when there can be problems with the access. I think good access management is becoming important, and yeah, to really have a good differential selection of the best possible valve. And one thing I can recommend is to always be very respectful with the procedure, because TAVI, I think TAVI is a very beautiful procedure, but I've learned a lot of respect. And there were times when I was thinking I didn't have annular rupture for 2 years, and then there was a year with 5 annular ruptures. So you will always be surprised, and but I think having a good understanding of imaging is very important, because you will see that the anatomy plays a major role in terms of procedural success, but also procedural difficulties. This is so important. Having a patient with tortuosity, horizontal aorta, makes the procedure much more challenging, and to have a good understanding of this is, I think, very helpful.
Great. I think those are great words of wisdoms to end the session and conclude today. So just leaves me to say thank you very much to Costanza for your presentation and summary of the work. Professor Kim, was a real pleasure to have you joining us. Thank you so much and sharing all your insights. I know certainly myself and everybody else would really appreciate your time and sharing all your experience and expertise. I hope you all enjoyed that session. And it'll be available to rewatch if anybody's interested on our YouTube channel, Journal Club channel, and we look forward to seeing you at the next session. So thank you.
Thank you very much. Have a nice evening.
Thank you.
Thank you. Thank you all.
Thank you, Prof. Thank you, everybody.
Bello.
Bah, bene. Ciao Carlo.
Ah, come stai?
Tutto bene? Come va?
Tutto bene. Una volta che era il pomeriggio riuscivo a vederla, invece mi sono incasinato, niente.
Vabbè, siamo finito adesso. Oh, grande.
Speravo.
Professore.
Oh, great, Professor Kim, as usual, impressive.
Fantastic. Wow, lots of little tips and tricks and
A lot of experience, eh?
2000.
A lot of value implant.
Mamma mia. Carlo, how are things in Ferrara? How's life?
Fine, thank you.
Everything good?
Fine, yes, we are. Everything's good. We are starting a lot of new things. So